So instead of giving you a lecture on Ferraris, and tonight you will see that I will present something a bit different. I'm going to discuss today about the chronic disease and aging, the epidemic of the 21st century. Well, I am involved deeply, and I have a vested interest like you, because first of all, I will be 67 in 1 week, and secondly, I have chronic diseases, you know. Well, it is evident. You don't need. So I will go to the epidemiologic evidence, then from systems, biology to politics, a clinical model of chronic diseases, and one thing I'm doing about, with the European Innovation Partnership on Active and Healthy Aging, it is integrated care pathways for airway diseases. So let's go to the epidemiologic evidence. Well, first of all, what do we call chronic disease? Well, it's all this. It is infectious. Can I have, please? Yes. So, can I have a pointer, please? It is infectious. It is also a genetic disease. Those who are working with cystic fibrosis, it's not any longer a disease of an acute disease. It is a chronic disease. And then you have the risk and protective environmental factors, which are of great importance and interest. And these lead to chronic diseases embedded with socioeconomic determinants and aging. So we need to understand all of this if we want to understand chronic disease and not only COPD, asthma, or rhinitis. Well, the next point is that chronic respiratory diseases represent really a very important disease, and this is the only guard slide which I will present. Interesting. Yes. Okay. So asthma in 2004 was 300 million. COPD was 63 million in 2007, and suddenly there was a big rise of 210 million in 2007. So, you know, WHO only gives estimates, which are better, like the wind is coming from the north, so there are 200 million. The wind is coming from the south, so there are only 60 million. But that's okay. Then you have allergic rhinitis, 400 million, sleep apnea syndrome, and others. So we should remember that chronic respiratory diseases account for more than 1 billion people. And now if we go to WHO statistics, what is important? This and that. This is the pink, and this is the purple. So, Walter, I honored you. So the pink is chronic diseases, and this is premature deaths. And you see that most deaths in the world are led by non-communicable diseases. The important point is that WHO published this figure. It's not very clear, but these are the important points: cardiovascular disease, chronic respiratory disease, cancer, and diabetes. And I can tell you that this has not been put by the societies of respiratory medicine, but by WHO. And since then, this has been recognized at the UN level. So chronic respiratory diseases, thanks to WHO, are in the group, and it has been struggled a lot to put them in the group. And then they said, well, risk factors. And this is very important. It is derived from the WHO slide because we need to improve it. But what is very important, it is that tobacco, pollution, physical exercise, nutrition, socioeconomics, and aging are all involved in most of these diseases. And some people say cancer is different. It is different in terms of management. It may not be different in terms of prevention, because you may prevent the same factors like tobacco smoking. Then, this study is remarkable. It is published by Barnett. It is on 1.7 million people in Scotland. What they found that there were comorbidities. So chronic disease not only have similar risk factors, but they're clustering in comorbidities. And the important is the color of the circle. So you have here, for example, diabetes in 2 places. Sorry, COPD in 2 places. Here, it is comorbidity with painful condition in relatively wealthy people and in poor people. So there is a clear imbalance in terms of socioeconomics in the generation and the management of chronic diseases. Well, this guy made also a very interesting study. These are the numbers of comorbidities when you are aging from 4 to 85 years. So if you take someone like me here, I should have already something like 8 comorbidities. Hopefully, I have some problems to work, and that's enough, I hope. The next point is, again, this is the deprivation in socioeconomic. These are the most affluent people, these are the least affluent people. And you see that they gain 10 years to get comorbidities. So we need to work, even in our countries, in the deprived populations, in order to get the best challenge. However, chronic disease can come early, and this is a study by Teresa To in Ontario. And what she found, it is that, in fact, in asthma, things are coming far earlier than in diabetes and all cancer. And what I have shown and proven to the Partnership on Active and Healthy Aging, it is that we need to start early across the life cycle. We should not consider chronic disease at 60 years of age, but we should consider in pregnancy. And you will see tonight that this is a reality now. So, what are the problems? Chronic disease are the major health priority of the 21st century globally. Because of prevalence and burden, because of comorbidities and risk factors, socioeconomic and economic burdens, inequities. This is unacceptable at all levels in the world. However, chronic disease and aging are intertwined, and care pathways for chronic diseases are vital in populations of all ages. So this is, I think, one of my most important slides. So from there, how can we go? Well, first of all, we need to recognize that the population in Europe, this is an EU slide, is tremendously changing. And you see that people over 90 years here are getting more and more. This was 1950, 1970, 1980, I cannot cope. 2005. Let's go. 15, 20. And so, if we want to tackle chronic disease, we need to include aging as well. And I'm not saying disease, but aging, which is a totally different topic. So now, how can we go? Well, first of all, we have to better understand, and some of you here have been in this paper, which is the first paper I published. You know, if I'm going earlier, we'll find Alvar, for example, Chris, some people. So the point is that we need to include systems medicine and integrated care to combat chronic and non-communicable diseases. And I think that this paper was the first to embed the two at the same time. So what was the concept? We start from socioeconomic determinants, lifestyle, environmental factors, which may be risk or protective factors. On this, you have genes and gender. And this is very important as well. We need to consider gender in all our studies. And then there is a biological expression of chronic diseases with transcript proteins target organ inflammation, but also remodeling. Many people in this room have a biological expression of chronic disease, but we do not know. And we need to go to a step further. And this step further is the clinical expression of chronic diseases with comorbidities, safety of severity, persistent remission, long-term morbidity, and the effect of treatment. Okay, with that, this is wonderful. But this is one part of the coin, and the next part is public health. Sorry, it is embedded by age. And the next is public health. So we need to have precise phenotypes in order to do patient stratification. And when we'll do patient stratification, then we'll be able to do health promotion and primary prevention, and eventually personalized medicine in patients who need. Most asthmatics do not need personalized medicine. Most rhinitis patients do not need personalized medicine. However, some severe asthmatics some severe rhinitis need. So we need to understand who are the patients who are going to be treated eventually at the pharmacy and who are those who are going to be treated by those who need really things. So now, is this translated in a research program? The answer is yes. And there are a few of you, like Dirke, who are in this program. And the program is now in its third year. It is Mechanisms of the Development of Allergy. This is an FP7 program of 16 million euros, 12 coming from the EU. What was the question? The question was, why have allergic disease increased? It is not why are they here, but why have they increased? And so we did a study from extremely well-characterized phenotypes to systems medicine. We are going to have 2,000 Ig microarrays. Dirke is going to do 7,000 epigenetics. We are going to have 1,000 proteomics, and transcriptomics may be a bit more complex. It's why I've made a spelling error. Well, we also will have eventually 23,000 DNA, GWAS. So what we have done, well, first of all, we have harmonized 11 birth or 12 birth cohorts from Europe. And instead of having 1 to 5,000 subjects, we got 44,000 subjects initially. And this harmonization tried to make two things. First of all, the classical phenotypes, and then the novel phenotypes. The classical phenotypes, well, people sat 2 days in Barcelona, and we make definitions. And then from these definitions, we harmonized 22,000 children at 4 years, and 19,000 children at 8 years. So this is the largest cohort in the world. And people coming from the north to the south of Europe, because we are very interested in the south. And then we also did cluster analysis, and I will give you just the answer of the cluster analysis, which is extremely interesting. So what we did, we harmonized the questionnaires, and this was done by Cynthia Oman, and I think that the paper should be accepted this week. And then we have a single questionnaire, which is historical and prospective for all the patients, and which can be used in all the cohorts, so data can be compared. Then, what we achieved, we had data of 44,000 children, and this was an NIH meeting. And I'm delighted to tell you that the paper is also accepted in the Journal of Clinical Immunology. And we got that. Well, this is a very busy slide. I know that José Panto may not like it very much, but to me as a simple clinician, well, the message is very simple. It is not IgE which matters the most in the disease, it is comorbidity. If you have probably a set of genes of comorbidity, then you will get the gene later, the disease later. If you have a set of genes with asthma or rhinitis alone, then you may lose the disease. However, IgE is considerably increasing this effect. So we have already something. And the statistical analysis with cluster, instead of increasing the number of clusters, reduced the number of clusters to 2, the non-disease and the disease, whichever Ig level. So I think that we have a very strong message here that we have made upside down. It is not allergy to disease, it is disease and allergy to disease, which I think is quite interesting. So we are here, then we select phenotypes, and we are doing IgG arrays, targeted proteomics, transcriptomics, GWAS by historical and epigenetics. And we have done that already. So we have identified some potential markers, and we go further, and I think that this is, well, Dirke Potsma has done a lot here, but in fact we have followed 11,000 children for 3 years with the same questionnaire. And now we have samples from these patients or subjects. And we're redoing exactly what we have done, that is to say, we're validating in birth cohort samples. And for example, in Groningen, they are going to do 6,750 epigenetics, which will be a massive IgE, 2,000 patients with 176 determinants. So it is a massive study. The problem is how we are going to analyze it. Well, we are struggling with that. And then we have also confirmation in animals and in immunology. And at the end of the day, we want to know new pathways, new determinants, and eventually new treatments of allergy. So system medicine can work. Now, the patient doesn't care of system medicine because the patient tells us, well, give me a drug and that's enough. So in Montpellier, we have started a clinical model of chronic diseases. Well, the first thing is that we think that we should change our mind from the classical phenotype, that is to say cardiovascular, COPD, diabetes, into a new one based on comorbidities. So in Montpellier, now we have a clinic which is not doing any longer, well, we are testing, but not doing any longer the disease by itself, but comorbidity. And Bianca Begay here, who is she? Where is she? Well, she did a wonderful study which was published yesterday in PLOS ONE, and she showed that in fact comorbidities are important only in severe COPD patients. So this study should be repeated. And I think that Leo's group did a wonderful study there. However, we need probably to understand patient by comorbidities rather than single disease alone, and then to find which are the pathways. We have in Montpellier a project. Well, it's possibly not as good as the Regione Emiliano-Romagna, but still we are working well and we are working together. And it is fighting chronic diseases for active and healthy aging in Languedoc-Roussillon. What we're doing many things, but one of them is to try to have a simple definition for severity of all chronic diseases. And this is based on a paper, where Jeff Drazen was one of the authors, which was to give the uniform definition of asthma severity to WHO. Well, it is based on risk. What is important? We don't care that the patient takes 10 puffs of Ventolin if it was just 10 puffs of Ventolin. But if the patient takes 10 puffs of Ventolin, he or she may get a severe exacerbation. So we are trying to work about the risk. And the risk is risk of asthma exacerbation, lung function loss, lung growth in children, and adverse reaction to medications. Does it work in asthma? Does it work in diabetes? Does it work in COPD? And I did that with Elizabeth Bell recently. So, first of all, you need to avoid risk. If you don't have a diagnosis, there is a risk of acute exacerbation, the risk of coma and death in diabetes. Do you have effective treatment? Yes, in asthma, ICS beta-2 agonist. In diabetes, insulin oral drugs. In COPD, it's less evident. But in COPD, you have something else. If you start early, if you avoid tobacco smoking early, you prevent COPD. Now, if you have in a country no treatment available, affordable, or used, then there is a risk of acute exacerbation. In our country, there is no asthma hospitalization any longer, or very few. In Madagascar, it's like it was 30 years ago, because they don't have drugs. But people who are dying in the UK are those who do not take treatment. So the next point is an incorrect diagnosis. How many of our patients are coming to see us with asthma treated with enormous doses of inhaled corticosteroids and long-acting beta-2 agonists, and they have something else? Very often it is bronchiectasis. Don't you have that? The next point is that if the diagnosis is correct, then you have difficult to treat disease. Compliance. If the patient doesn't want to take a treatment, too bad, but you cannot do anything. Inhaler misuse, it is enormous. And the risk factors. If someone is continuing to smoke, there is nothing. In diabetes, it's exactly the same. And then you are left with two phenotypes. Controlled treatment-dependent disease, that is to say, if you stop insulin, if you stop your treatment for asthma, 3 days later the patients are in hospital. And then you have uncontrolled treatment despite treatment. Despite treatment. Whatever you do, you have the severe asthmatic, you have the severe insulin-dependent patients. So if we could go to the same, the same thing here, in all people with all chronic disease, it will help in public health, in general practice, everywhere, in order to get a better phenotype. Now, what we're doing specifically in Montpellier is a chronic disease clinic. The chronic disease clinic is patients with either or chronic respiratory disease, cardiovascular disease, kidney and metabolic disease, will get exactly the same assessment. Well, we're going to move to a better thing with tailored, but today it's the menu. So we have a common questionnaire for risk factors in disease. We have specific questionnaires. We have exams, clinical, biological, ECG, FEV1 and beta-2 and echocardiography. And then we can screen comorbidities. From this screening, we are doing three things. First of all patients have quality of life, depression and anxiety questionnaires on tablets. And then people over 65 are assessed for frailty and risk of fall. And then we can define, according to guidelines, which are Haute Autorité de Santé and NICE, what is the severity and what is the treatment needed for control. And then we can address the patient for force or frailty if there is a risk. However, there is a further step, which is the risk assessment, because we need to go to specialist advice when needed. And in this case, if you have a high risk of cardiovascular disease in a diabetes patient, then you send the patient to the specialist. So we are testing this, it works, and I think that it is interesting because we have screening, severity, and risk assessment. The next point is that this is the situation in France, and you have the numbers of doctors across France, and here you have the number of young doctors across France. And you see that yellow is going to be enormous. I don't know what is the situation in Italy, but I think that in the Abruzes or in many parts of Italy, you may have the same situation. And in fact, our program is also a mobile clinic going into the remote places of the area in order to get an interoperable assessment across all the regions Languedoc-Roussillon. And this may be transferable to other regions as well. Well, now I would like to go, we have started to understand what was the mechanism. We have seen, there is a possibility to understand the patients better at the clinical level, but now we need to do implementation. And this is what we're doing with European Innovation Partnership on Active and Healthy Aging, and it's called Airways Integrated Care Pathways. Well, for those who do not know, Dr. Verrazzi knows very well, but for those who do not know, this European Innovation Partnership on Active and Healthy Aging, it's possibly the first time you listen to it today, but I promise you that you will know it very well in the next 2 to 3 years. This is probably one of the most important programs in health which has been started by the European Union. And it will, if you go to the website, you may take 5 days to see what is there. It's a bit too complex. But I tell you that there are 500, now possibly 500 good practices, and it's booming. And the Regione Emilia-Romagna is sending a mail every 2 weeks with a new good practice. Congratulations, we cannot follow you. We will try. So this is for a triple win, and the triple win is EU citizens healthier, more active and independent until old age, social and healthcare systems more sustainable, dynamic and efficient, competitiveness and market growth of innovation in the aging sector fostered. And hopefully, in Montpellier, we have one of these things, which is healthy life use, and we're trying to understand and to assess healthy life use in regions. So this will be something you could take from our region. And in fact, there are 5 groups, 5 thematic areas: prevention, screening and early diagnosis, care and cure, whatever it is. But the interesting thing is that Airways ICPs is a paper which will be submitted less than a month to the European Respiratory Journal. It has already 450 members and 200 authors. All of those who are here and want to participate to this, please come, because what we want to do, first of all, to collate ICP national programs and guidelines used in the countries and other European countries for respiratory diseases. Do you know the Portuguese respiratory program? Who knows the Portuguese respiratory program in the room? Well, do you know that it is the only program I know which incorporates all respiratory diseases in a single program? Don't you think it would be worth to read it before we start another program? So this is what we're doing. We're collecting what is existing, because it's not necessary to reinvent the wheel every day. And then we will go forward. And since the EU is making a repository, so all the people who have been in Airways ICPs, and now there are, I tell you, 200 authors and 450 people. Yesterday I got 20 people from Slovenia, last week 30 from Serbia. I'm expecting the Croatians to come and everyone. So we're going to ask to all of this, send us what you have. And this will be put on the EU website. And people will see what is there. And then a group of experts may look at these programs and say, well, I'm interested in this, I'm interested in there. Because I'm not speaking about Italy. I'm not speaking about the UK or Netherlands. I'm speaking about people like Serbia, like Croatia, like Montenegro, well, who have no program. And they will benefit greatly from what you're doing. So this is the first step of Airways ICPs. The second one, well, what are the important questions in respiratory medicine and comorbidities in the elderly? Example, where is a guideline on old age asthmatics who have a cardiovascular disease and who need to take inhaled beta-2 agonist and oral beta blocker? Do you have this? So if we don't have that, we need to develop it. And this I would like to do it with the regions. That is to say, the regions should take the lead and say, well, we have three important questions. We want to answer to these questions. And we're going to get the answer here because we've started this. We've done a three-step Delphi. The first one, we asked to 25 people in each category for rhinitis, COPD, asthma, rhinitis, asthma, COPD, and their comorbidities, and important issues in children to improve healthy aging. What they wanted, we had a 90% response rate. Then we're putting the 100 questions for each in a website, and 80 people will answer what is their choice from 0 to 10. And then we will know what are the important, it's not a textbook, but what are the important questions in the elderly. And from this, we will go to develop integrated care pathways for asthma, COPD, and comorbidities in the elderly. So, what is the real problem now? Asthma, probably not except in a small sample. Asthma and rhinitis comorbidity, it has been tackled. COPD, we probably know, but we don't know what is the overlap syndrome and what is the overlap syndrome and comorbidities. Because what we want to do is the following. Well, these are the death rates and hospitalizations in Finland for asthma. So we can do something and we have solutions. And not only in Finland, but also in Salvador de Bahia. So what can be done in asthma in a wealthy and extremely well-organized country can be done also in a country which might be said to be less organized. However, guidelines and organization of care do not reflect the reality of comorbidities. So what I'm proposing is that we take a defined problem, the comorbidity between asthma and COPD in patients over 70 years of age, and have also an idea how to define the age, and then to go to comorbidities. And this is what the regions and the governments should do. So you have the scientists, the governments of the region, and all of this embedded into the Healthy Aging Partnership. So you see, ladies and gentlemen, that we have plenty of things to do. And finally, what I would like to say is that there is an epidemiologic evidence that chronic disease and aging represent the epidemic of the 21st century. We should know better using system biology. There are models for chronic diseases. The European Innovation Partnership on Active and Healthy Aging can help. And tonight, I will discuss something which is possibly even better and more important. It is health promotion of healthy and active aging across the life cycle. Thank you.